Doctor, talk a little bit about your background in fibromyalgia and explain exactly what that is. I mean, it's a term that I think a lot of people hear, but maybe might not understand.
Yeah, fibromyalgia is one of the topics I'm here speaking on, and it is a very confusing topic. It's confusing not only to lay people, it's confusing to doctors and various clinicians, and I honestly have to say the vast majority of my healthcare provider colleagues don't know much about it. Or they think they do, but they have wrong ideas and wrong opinions. And in their defense, unless you really dive into the literature and really spend a lot of time digging in, it's easy to be confused about it because it's become this sort of catch-all umbrella term when people have vague symptoms, including fatigue, tiredness, and they're achy in a lot of places. So they have a lot of pain, let's say, in their muscles. And particularly if they also have cognitive dysfunction, they just don't think right, they have some memory problems, or they have mild depression, they're often just almost reflexively labeled as having fibromyalgia. The problem is, true fibromyalgia, which we call classic fibromyalgia, if you look at the literature on what they're really trying to describe, it's true that a big component of that is fatigue, is achiness all over the body, is cognitive dysfunction, depression, sleep disorder, and the like. But there are many, many other ways that you can get those same type of symptoms. And the problem is it's automatically being called fibromyalgia, and that's not the case. You really need a clinician who really understands fibromyalgia, which we really more correctly would call a global pain processing disorder. And the preferred term now in the literature, for those of us who publish in it, is something called central allodynia. Now that's a mouthful, but allodynia simply means when an individual perceives a stimulus that should not be painful to the average person, they perceive it as pain. For instance, if I come over to you and just lightly touch your arm, you perceive it as light touch. It doesn't hurt. You know, it's just light touch. You know that I just touched you. Someone with classic fibromyalgia may perceive that as pain. They may perceive the breeze blowing on them as pain. And the problem is not where the stimulus occurred. In other words, if I come over to a fibromyalgia patient and I squeeze one of their muscles in their arm or their leg, they'll have pain there. But there's no problem at all with the muscle, with the area that I squeezed. In biopsy studies and electrical studies, there's nothing wrong with that tissue. There's nothing wrong with the pain receptors. The problem is in how their central nervous system perceived that stimulus. That's a very different thing than a whole host of other problems that can make people have achiness in the muscle. If you are anemic or iron deficient anemic, you're not carrying oxygen well, you will go into an anaerobic metabolism that will cause a lot of acidic waste products in your muscles, which will make them hurt. Anyone who's exercised in a way that they're not used to knows for a couple of days later their muscles are going to hurt because they went into this aberrant metabolism temporarily. And they have all this lactic acid in their muscles. So if you go squeeze their muscles, they hurt. And imagine if you were in that kind of metabolism chronically, at least to some level, you would have chronic levels of muscle achiness. You would have a relative lessening of your energy. You would be fatigued. And since the brain requires a tremendous amount of energy, or ATP, you would have difficulty in having sharp thought or cognitive function. So there's a metabolic reason, something as simple as being profoundly iron deficient, which is not uncommon, okay? But also, the oxygen by the blood cells is being delivered to the cells so that it can be used in the mitochondria. The mitochondria are the powerhouse, the furnace. That's where the energy is made. If there's problems in mitochondrial function, and this is common as we age, if you don't produce energy well, you will have all of these same symptoms. You will have energy deficiency. You will have achiness in the muscle. You will have cognitive dysfunction. And mitochondrial uncoupling or mitochondrial dysfunction is far more prevalent than is a pain processing disorder. So you're much more likely to be diagnosed or labeled with fibromyalgia when you really have another valid explanation for your symptoms that is not really fibromyalgia. It doesn't mean there's nothing wrong with you. It means that they called it the wrong thing. What's the problem with calling it the wrong thing? Well, primarily is you get the wrong treatment. Okay, you're going to get the treatments that are used for true central pain processing disorders or fibromyalgia when your problem isn't central. It's in the periphery, it's in the mitochondria, or you need iron or whatever it may be. Another common reason why people get mislabeled with fibromyalgia is they have an unappreciated thyroid condition. They don't have an overt, in-your-face hypothyroidism. They have a more subtle hypothyroidism. Sometimes we call it subclinical hypothyroidism or peripheral hypothyroidism, where you don't convert one of the thyroid hormones to the active hormone known as active T3, or your cells are a bit resistant to thyroid hormone. So there's ways to treat that, but only if you know it's that. You have to test for it, be able to tease that out, and treat that appropriately, and then the patient gets well. But if you give that patient, because they were mislabeled with fibromyalgia, a drug for fibromyalgia, they don't get better. Okay, so it's all about correct diagnosis. In my opinion, personally, seeing a lot of fibromyalgia patients over 20 plus years, and in having a lot of colleagues who do, because I co-publish with a lot of people at different academic centers in fibromyalgia, just from us sort of talking to one another and communicating, I think you'd find a consensus of people who see a lot of fibromyalgia, that many more people that come in claiming they have fibromyalgia really have some other reason for their symptoms rather than true fibromyalgia or classic fibromyalgia or pain processing disorder. Now, that might be because half of them got diagnosed with fibromyalgia by visiting a website or WebMD, or their neighbor told them they had fibromyalgia, but a lot of them were told by their family physician. I have people come in from rheumatology centers of excellence in major academic teaching hospitals with the diagnosis of fibromyalgia or the label of fibromyalgia on one of the drugs for fibromyalgia. And when we actually do a good history, a good physical, all of the right laboratory rule-outs, we find out they have some other reason for their symptoms. And a lot of that stuff had never been done, which I think is sad. But it's sort of this reflexive diagnosis of fibromyalgia, and a lot of physicians don't want to deal with it because they're thought of as difficult patients, right? Because there's no magic bullet. They don't get better right away. They're complicated patients. They have chronic illness sort of things going on, and a lot of doctors just don't want to deal with them. So when we see someone with fibromyalgia, or they say they have fibromyalgia, we file that in our head and we say, well, they might be right, but they might be wrong. And we go about a very systematic process of ruling out all of these other things, not only overt medical conditions that should have been caught, but the more functional, subtle things. So we'll look at their metabolic uniqueness as an individual, such as using testing like organic acid testing, looking at mitochondrial energy production, and if there are problems there, trying to repair those weak points in their metabolism. We'll look at their thyroid function. We'll do all of the standard blood rule-outs to make sure they don't have some other medical condition. And then if we really think they do have classic fibromyalgia, they need to have all of the right things lining up to support that diagnosis. For instance, they have to have something called global pain. They have to have pain everywhere. They have to perceive pain all over the body. It can't be localized. If the pain's just in their upper shoulders and neck, or along their spinal, in their torso, along their spine, or if it's just in their pelvic area and radiating down the legs, that is not fibromyalgia. Or they may have problems in classic areas of the body that are known to have either muscle tightness due to stress, due to repetitive motion, things called trigger points, these little knots in the muscle, which can be acutely painful, particularly if you put pressure on them, and can actually cause referred pain. These trigger points can kind of collect around the body and cause a condition known as myofascial pain syndrome. Myofascial pain syndrome can cause significant pain in regions of the body, even referred pain away from the initial area of problem in the muscle. That is not fibromyalgia. That is myofascial pain syndrome. The problem there is truly in the muscle. So peripheral therapies that address the muscle, that are physical in nature, things like deep massage or different types of myofascial pressure point therapy, acupuncture, electroacupuncture, stretching, chiropractic or osteopathic manipulation and mobilization, all of those even muscle relaxers, all those kind of things can be helpful if it's a myofascial pain syndrome. The problem is a lot of people that really have fibromyalgia get a lot of that stuff done. It doesn't help them a lick. It just hurts them. It's like torture for fibromyalgia patients because they're only perceiving pain out there. There's really no problem there. So you need to have a clinician who can put their hands on the patient and can tease these things out. Do they really have true physical problems in the somatic tissues, the muscles, the ligaments, the tendons, the soft tissues?